Thank you, Dr. Anahita, for a comprehensive presentation on necrotizing stromal keratitis. It really is a challenging entity, and every patient of NSK presents a different challenge to the clinician. So, coming to our last talk, where I'll be talking about some of the top pearls for management. Here, I will be summarizing some of the aspects which we have discussed already in our IC and just summarizing what you should take away to your clinics from this instruction course. So the biggest aspect of HSV is that it's difficult to diagnose because it is a great mimicker. It mimics so many different types of infections, and it can present in any way. It can present affect any layer of the cornea, and it can present in very different ways. Second is that it's very challenging to treat because it requires long-term therapy, recurrences, steroids, no steroids, oral, topical, etc. There are so many arms of its treatment that it becomes challenging to treat, and every patient might have to follow a different path of treatment. So to make the diagnosis easier, when you differentiate for a epithelial keratitis, differentiate a true dendrite from a pseudodendrite, the pseudodendrite will not represent usually a true ulcer, and there will be an absence of dual staining in these patients of pseudodendrites, and there will be no terminal knobs which are seen in patients of HSV epithelial keratitis. So as you can see in the pseudodendritic picture, that there are no terminal knobs noted here. Second, as I discussed before, look for the clues that support your diagnosis, especially the history. History is very important in HSV patients. Look for footprint scars and the vascularization and ghost vessels. So let's look at this case, who was a 48-year-old female who presented to us with on treatment for 9 months with recurrent episodes of redness and pain. You can see a lot of infiltration here and a lot of vascularization. So patient was being treated with antivirals and steroids with waxing and waning course. And we did a corneal scraping for the patient, and it came out to be microsporidia. So a PK was done for the patient. The patient had a good outcome with an eccentric graft. The important lesson from this is that very often these patients of HSV or non-HSV mimicking HSV actually have visited many consultants and many clinicians, and they have diagnosed as HSV. And they also write previously known case of HSV. And the patient comes to you, you also write previously known case of HSV. So don't fall for the trap of diagnostic momentum. Look at every patient from the beginning as a new patient, as a new aspect, and then retrospectively you can go back that yes, this might be HSV. But if we think that this has been diagnosed case of HSV, then we also treat in the same lines. Second, as I discussed before, that steroids need not be started early in even patients of immune stromal keratitis. So you don't need to rush to add steroids because the final outcome remains same. So whenever you are in doubt, do a corneal scraping. If you are suspecting any other infection, there's no harm in doing a corneal scraping, and even a basic smear will tell you about many of the organisms. And as HSV is a great mimicker of other infections, the other infections can also mimic HSV. So keep in mind these three important points. To make the treatment simplified, in patients of epithelial keratitis, topical ganciclovir is preferable because it has better tolerability or acceptability. It does not cause blurring, but it is costlier. So you have to see in terms of what the patient can afford. There's no difference in efficacy between these two agents. Second, oral versus topical therapy in patients of epithelial keratitis. As I said, prefer oral Acivir when there is an associated ocular surface issue, dry eyes or neurotrophic component, or it's a graft case. Then you prefer oral antivirals over topical for epithelial keratitis. This thing which we have often seen in our clinics is that a lot of clinicians give dual therapy. They'll start on oral as well as topical, even for epithelial keratitis. So there's no evidence that simultaneous use of two antiviral agents will accelerate healing of the HSV epithelial keratitis. So keep only on one agent, whether oral or topical. Patients with a longer healing time in epithelial HSV keratitis, these are the patients who have a large geographic ulcer or who have a limbal lesion, because there is more inflammation in limbal lesions. Patients who have associated stromal inflammations. There are many patients of HSV epithelial which will present with stromal infiltration as well. So a patient of geographical ulcer is likely to develop a geographical ulcer more in cases of delayed treatment. if the patient has been given topical steroids and or if the patient is immunocompromised. In these cases, there can be sequelae of having infiltration and residual scars in epithelial keratitis also. But in these patients, you can give soft steroids because these are superficial lesions, but antivirals need to be continued as long as the patient is on steroids. So let's look at another case. This patient had presented with a good visual acuity and was on steroids along with antivirals. But you can see there's a lot of cellularity here. You don't appreciate any epithelial defect. But when you stain the patient, you actually find an epithelial defect. And when we did a scraping for this patient, it turned out to be pythium keratitis. The patient, after stopping the steroids, has significant flare up. So from 2040, the patient went to finger counting close to face vision because of stopping of the steroids. So again, no, you should not rush to add topical steroids. So in cases of immune stromal keratitis, make sure that there is no other infection before you consider adding steroids. And again, as we discussed, immune stromal keratitis, do not rush to stop steroids as well. So these two things you should never do in immune stromal. And as we have discussed the regimen previously, a very slow tapering of the steroids in patients of immune stromal keratitis is needed to prevent recurrences. That's the most important thing, that you reduce the inflammation completely before you stop the steroids. And that completely means even at microscopic level. So what is the duration of prophylactic therapy that is needed? So how long should you continue the patient on asevere prophylaxis? So there are many factors that you consider before you consider stopping asevere prophylaxis. When did the patient have last recurrence? How many recurrence patient has had on prophylaxis itself? Is the patient one-eyed or has a precious corneal graft? Is there a bilateral disease in the patient? And is there any evidence of renal toxicity on renal function tests? So also you have to understand that patient will have benefit of oral Isivir only till the time the patient is on oral Isivir. So no clear guideline is there for how long you should continue it, but you can continue it as long as possible, especially if the patient is having immune stromal keratitis and having recurrences. Consider stopping when there has been no recurrence for at least last 6 months, and that is off any form of steroids. Okay, so in these patients who have not had any recurrent episodes after stopping steroids for at least 6 months, you can consider stopping the prophylaxis. How frequently renal function tests should be done? Ideally 3 months is what is dictated, but even 4 or 5 months is sufficient enough to get the renal function test. Most important aspect of treating HSV is the counseling. You have to tell the patient this is not a local infection in itself, it's a local and systemic infection. Treatment will not cure this disease, but only reduce the recurrent episodes. You have to make them understand the prophylactic therapy has to continue for much longer if the eye needs to be saved. The recurrences may still occur on prophylaxis. The patient should note this, because then only the patient will stick to you as a clinician. Otherwise, they will keep searching for another clinician who can stop the recurrences. And explain to the patient what are the warning symptoms of recurrence, so that they seek early care and you can initiate treatment early, so that the scarring post immune stromal keratitis is much lesser. Vision will get affected with repeated episodes for the patients, so they should know the consequence of stopping oral prophylaxis on their own, which patients often do. And you can explain to them the need for repeat testing of renal function tests when the patient is on oral prophylaxis. So thank you everyone.